Perfect. So welcome to everybody. 2 minutes after 5, we will start with this webinar. I'm very happy and honored to have the opportunity to introduce you to this webinar about recurrent acute liver failure, the current landscape. We have two really great speakers for this webinar, Dominic, Lenz and Georg Vogel. Both are very experienced, especially also on this field of recurrent acute liver failure. Dominic is the leader of the working group for pediatric liver metabolic disease at the University Hospital in Heidelberg in Germany, and published a lot of groundbreaking discoveries in the field of recurrent acute liver failure, including NBAS, GIL1, LAS1, and very recently DLDD, and great overview about pediatric acute liver failure and hepatology. And he's also the leader of the acute liver failure group in the EN Rare Liver Registry, or sorry, not in the registry, in the network. And Georg, also a very, very great speaker for this topic. He is the chief of the pediatric gastroenterology hepatology working group in Innsbruck, in the University Hospital in Innsbruck, Austria. He also published on this topic more in the field of mitochondrial aspects, also for acute liver failure or recurrent acute liver failure. And the webinar is divided in different parts. I think, Dominic, you will show this soon, and Dominic will give the introduction about what they will talk about. So now just let me mention that this webinar will be recorded and can be seen on the ESPGHAN YouTube channel later on. And if you have any questions, please feel free to put them in the chat, and we will discuss it after the talks with you. Okay, thank you very much. And I'm very excited to see this webinar.
Thank you, Norman, and I feel honored to have been invited to give the talk together with Georg Vogel from these two scenic cities that you can see here, Heidelberg and Innsbruck, about recurrent acute liver failure. We want to start with a short overview what we're going to talk about. We were going to share these chapters between the two of us. I start with a short introduction. While then Georg talks about disorders of energy metabolism as a group of disorders leading to recurrent acute liver failure before we come to protein translation and metabolism defects. And then then going over to endoplasmic reticulum homeostasis and transport disorders and talk a bit about management outcome. And then we are happy to discuss more questions or things on that with all of you by the chat. So starting with definition, characteristics, and overview, I just want to repeat what is the definition of pediatric acute liver failure. And most of us use the inclusion criteria of the Pediatric Acute Liver Failure Study Group in the US, published in 2006. Inclusion criteria were acute liver injury, measured by hepatic transaminase, so bilirubin, and severely decreased liver function, not corrected by vitamin K. And in case of hepatic encephalopathy, the coagulopathy just up from 1.5 INR accounts for that, and absence of known chronic liver disease. And we talk about recurrent acute liver failure. It's recurrent episodes of PALF without symptoms in the interval. Then we need to discuss if this is really absence of a known liver disease, because there has been an PALF episode before. When I came across this first time, it reminded me of this definition that I had seen before: severely increased liver enzymes with steatosis in this context, encephalopathy and hyperammonemia episodes triggered by febrile infections, very similar to what we said RALF episodes are, but that was the definition of Raya syndrome in the 60s. And I want to bring that up because I think that has a lot of to do with each other, and we're going to get back to that in a moment. When we look at these, the overall picture of recurrent acute liver failure, it's, as said, we do have a recovery phase that you can see here after a PALF or liver crisis episodes. And normally they are triggered by, for example, febrile infections, or any trigger can be fasting as well, protein excess and protein metabolism. And then there's a recovery. Onset of most of these of those diseases is at infancy. And of course, that such a picture can be caused by repetitive infections or toxin exposures. But in general, this is suggestive of an underlying genetic or metabolic disease that's just predisposition for such liver failure episodes. And determining the cause can inform specific treatments, prognosis, and liver transplant, and makes us and the families the life a lot easier to be in a good company for them. But keep in mind, every recurrent acute liver failure starts with a PALF episode. So how can we distinguish maybe at the first presentation, is this a PALF syndrome or a RALF syndrome? And in the study Norman mentioned in 2023 in Hepatology published, we compared we looked for genetic causes for liver failure, and included as well nearly 60 patients, 59 with recurrent acute liver failure. And when we wanted to see, is there any difference between those cases, those children with these presentations, we would find a significant difference in the hepatic aminotransferases, in the AST and ALT levels that are highly elevated in the RALF group compared with the ALF group. However, this is of course biased a bit by the etiologies behind, and I think one of these biases is NBAS deficiency with a high percentage in the RALF group, and they normally have very high hepatic transaminases during their crises. Bilirubin was tended to be lower, so significantly lower bilirubin, so mainly hepatocytolysis in this RALF syndrome. Not sure if this helps. And then the other perspective is there a difference in survival? And yes, we do see recurrent acute liver failure goes in line with a better survival. So this is overall survival, not native liver survival, while ALF is a severe, can be very severe. We do see that RALF often survive, but this is also clear because if you have RALF, you have at least survived your first ALF. Hence, I think this is only showing that the entities behind recurrent acute liver failure do have some mortality, but a lot better than the PALF in general. Here you see it's especially in the first month of life, mitochondrial disorders leading to then death as well, and that influences a lot in this statistic. And looking at the biopsies results, again, comparing ALF with RALF cases, we did see significant more steatosis in those in the biopsies of those patients. That brings me back to the question we had on the slide with the Raya syndrome again. And looking at the Raya syndrome, said steatosis is one of the definition parts. I was mainly diagnosed in the 60s to 80s. 80s was had high cases to be reported still, and then got reduced more. And when I found that very interesting, in 2022, a group from Paris. They looked back at all the Raya cases where they had still biosamples or patient access to, and they had diagnosed in their decades before 58 children with Raya syndrome, and now they reanalyzed with genetic means and metabolic tests again, and they found in 71% of their children that presented with Raya, but diagnosed as Raya syndrome, they found the metabolic disorders beyond. And you can see what kind of disorders they found, and more than half of it were urea cycle disorders, then were fatty acid oxidation deficiencies and other energetic metabolism disorders. NBUS, we talked already, and among those three others. So that's why I think we should really have a look. I don't know if Raya exists. I think there is an underlying genetic or metabolic disorders, and we should look at, and mainly which causes of PALF are also causing recurrent PALF. Looking here again at PALF study group, that's the whole study cohort of 1,144 children included in the PALF study group between 1999 and 2014. Then we had 10% of those children had a metabolic disorder as a cause. And when you look at the metabolic diseases that have been found in this cohort, it's around 100 children. These are the diseases that have been identified here behind. We do see the ones that can cause recurrent acute liver failure are the mitochondrial disorders, urocycle defects, and fatty acid oxidation disorders called disorders of protein metabolism and energy metabolism. But I think at least the major group is hidden here behind. So 43% of the children have not been diagnosed with a certain disease entity because they have no specific biomarkers. That was before the introduction of next generation sequencing into the field of the diagnostic that we now couldn't imagine anymore, that we don't have fast genetics. So we analyzed those cases in the study that we published in Hepatology, and included 264 children, and nearly 40% of these cases have been done found a genetic cause behind the unsolved acute liver failure, recurrent acute liver failure cases. Nearly 60% for the recurrent, and around 30 for the ones that had one episode of acute liver failure. What do we find here behind? That you can see the groups here on the bottom. We had more than 30 distinct disease genes, the disorders of Golgi transport, vesicular trafficking, with NBUS deficiency being most prominent. As said, this might have influenced the ALT, AST levels in the RALF group. Then we have the mitochondrial disorders as energy metabolism that you can find here in the brackets. And then another disorder group that we didn't talk before, that the cytosolic tRNA synthetase deficiencies are involved in protein translation. So that's how we structured our talk as well. We will talk about the disorders of energy metabolism, protein metabolism, and endoplasmic reticulum homeostasis, and Golgi transport. So far, the introduction. So I hand over to Georg Vogel from Innsbruck, and I hope that goes smoothly now. You just enjoy about energy metabolism.
Yes, thank you. So you can put on the next slide already. I'm going to dive in with a case description of a young girl we've seen at our center. She was referred to our center from peripheral hospital. She was referred in an acute liver failure episode with a pre-established diagnosis of TRMU deficiency. So this is a gene encoding for a mitochondrial tRNA to thioridulase, and that was her third episode already. So as this would fulfill the criteria for RALF. And she was in coagulopathy when presenting with increased bilirubin, but not that high of transaminases. Lactate was increased and sodium. But she was in second to third degree of hepatic encephalopathy already. And the episode occurred under full specific treatment or supplementation for TRMU deficiency, being L-cysteine, N-acetylcysteine, vitamin C, and selenium. So we opted for hemodiafiltration, and due to the progressive course in hepatic encephalopathy, we did a workup for living donor liver transplantation with the mother as a donor, which went unremarkable, and also the course after discharge was unremarkable. Next one, please. So what is TRMU deficiency? It's actually also referred to as transient infantile liver failure. It's due to the deficiency in properly functioning tRNAs for protein translation in the mitochondrium. So this 2-thiouribulase is important for glutamate, glutamine, and lysine tRNAs. It has its onset during infancy, as you see on the right-hand side with the graph of episodes of acute liver failure occurring already quite early during life, during the first months of life, usually triggered by febrile infections, and cease to occur after the first year of life. Usually, children present with liver dysfunction, as ALF, for example, with lactic acidosis, and this is due to a combined deficiency in the respiratory chain. So you need to press, yeah, perfect. It's transient. Some patients, as we found out in a larger cohort, have episodes of recurrent acute liver failure, and only a minority of patients had developmental delay. Next one, please. What we also found is that although it's called transient, there is a third of all patients died during an episode of acute liver failure or ALF episode, and multi-organ failure due to acute liver failure. So this is always the question: when do we opt to escalate therapy, or when do we wait a little longer? So it's always good to have eventually the option to transplant in the backhand, but this is going to be touched by Dominic later. And we found that the survival probability is actually differs a little on the genotype you have. So if you have loss of function mutations, you maybe have a worse survival probability than with missense mutations, but trend-wise, it's not significant in this small cohort. It seems that if you opt for liver transplantation in a severe episode, survival probability is better. Next one, please. What's also interesting is that the symptomatic treatment, if you want to give more, it's always a cysteine source, because the assumption is that cysteine is an important substrate for the 2-thiouribulase, and with that you do something beneficial for the mitochondrial tRNAs. What we found is that this is the case also in the cohort. So survival probability is better under supplementation. And of all supplementations, the common denominator was N-acetylcysteine. And then you can again argue whether this is only the cysteine source or whether it's also its capacity as a reactive oxygen species scavenger, because if you have a respiratory chain deficiency, you might end up with increased ROS levels. However, it did not, so the supplementation did not impact on native liver survival. Next one, please. Also next slide, yeah. So another disease of the energy metabolism is the dehydrolipoamine dehydrogenase deficiency, short DLD deficiency. And this is also already, you might recognize the E3 from one of Dominic's slides as cause for Raya syndrome. This is a dehydrogenase that is important for at least 3 energy metabolism pathways. So it is important in complex with other dehydrogenases, as the pyruvate dehydrogenase, the alpha-ketoglutarate dehydrogenase, or the branched chain alpha-keto acid dehydrogenase. Next. Usually patients present with a severe neurological phenotype and lactic acidosis, but next please, there is one particular point mutation, the P-glycine 229-2 cysteine, with a predominant hepatic phenotype. It initially has been identified in an Ashkenazi population, but there are now also patients outside of these populations identified. Next one, please. So there is a smaller cohort, as you see. Usually we end up with small cohorts, but this is what we know so far, that the presentation is a little more spread out. It's within the first 5 years of life. Patients have recurrent episodes of acute liver failure, lactic acidosis. This is the typical presentation for disorders of energy metabolism. And in this respect. And crises are less frequent with age, and cognitive impairment, unlike the other forms of DLD deficiency, are rather unlikely. Next one. When it comes to treatment, we don't have many options. We can substitute thiamine to boost pyruvate dehydrogenase function, riboflavin. If you do have a cognitive impairment or a neurological cause, you can opt for a ketogenic diet. And again, you can try N-acetylcysteine as a ROS scavenger. So far in the cohort known, there are a few fatal cases, even one after liver transplantation. Next one, please. So this is mitochondrial fatty acid oxidation defects. So I'm just going to briefly touch them in this one slide. You've also seen them in a few cases of formerly known RIA in the French cohort. Typically, these disorders present with hepatomegaly and steatosis, but there are also known ALF cases, about 10 to 30% about in 4 cases, and also RALF cases have been reported in acyl-CoA dehydrogenase long chain deficiency, as well as PALF cases. And as Dominic mentioned, the first PALF case might be transitioning into RALF later on in carnitine transporter deficiency, which is also a prominent example of forwards. Next one, please. And just as a last slide, also very important, mitochondrial DNA depletion syndromes or hepatocerebral syndromes. In that case, patients present with hypoglycemia, lactic acidosis, failure to thrive, and nystagmus, hypotonia, and peripheral neuropathy. Usually mortality is quite high, but milder cases are reported, which is important if you eventually opt for liver transplantation. Of course, hepatocerebral affection would rather not be a good case for transplantation. 2 genes are more prominent in that group. One is this oxyguanosine kinase, DGUK. Typically, early onset, rapid progression of liver cirrhosis might be also the basis for early onset hepatocellular carcinoma, might also give rise to PALF. And one RALF case was reported in Dominic's cohort, as well as for MPV17, a gene which is important for membrane potential of mitochondria. And with that, I'm going to hand over to Dominic again with disorders of protein translation and metabolism.
Thank you, Georg. Then I take back the microphone, talking about protein metabolism and translation, starting with the case report as well. That's a young boy that came with 9 years of age or came with 6 years of age into our care. He was small for gestational age and had a history of intrauterine growth retardation, prolonged neonatal jaundice, and a failure to thrive. And then from 9 months on, and he had episodic liver enzymes elevated after infections, steatosis, and fibrosis with cirrhotic foci in the biopsy. And then a very severe decompensation when he was aged 6 years. This was triggered by an influenza B infection and full-blown acute liver failure. Picture was present with encephalopathy and status epilepticus. And I found this MRI very impressive to see how bright, shining are the basal ganglia, the thalamus in the brainstem had an edema and a high lactate peak. We were very worried about this boy, and the genetics then revealed afterwards only pathogenic variants, allelic pathogenic variants in LAS1, giving rise to the diagnosis of infantile liver failure syndrome type 1 had been described in the Irish traveler cohort. 10 years or 2013. Further symptoms of this boy and in general for LAS1 deficiency is anemia, hypertonia, developmental delay, can be in a bright spectrum and only mild. And this boy had actually a full recovery while he was cognitive and in a coma state first, and then had transient cognitive and articulation deficit after this episode. He fully recovered with rehabilitation, and now 9 years old. So normal cognition, attends regular school, rare mild liver enzyme elevations after triggered by infections, and has overall very good overall health. So the picture is really PALV episodes that might be triggered, and the onset is later than in the mitochondrial disorders. We see age of onset in a median at 9 months of this disease. And they can have episodes of encephalopathy that are independent of an ALF episode. So that's interesting. There's a second mechanism. It's not all hepatic encephalopathy. They can have muscular hypertonia and developmental delay. And they could be, if you look back in children with PALF and they have intrauterine growth retardation, quite severe microcytic anemia, hypalbuminemia, that should prompt thinking of LAS1 deficiency. What is that? And you might have, there's a parallel to TMU, which is also involved in protein translation, but not in the mitochondria. We're talking about the cytosolic amino acid, TNA, synthetase deficiencies, where the tRNA synthetases, they couple the tRNA to the cognate amino acid to be then introduced in the growing chain of a protein during translation. And if this is hampered by one tRNA synthase that is not working, of course, this might have impact on the multi-system presentation and different organ systems. In those 3 disorders, LAS1 for leucine, MARS1 for methionine, and ERs for isoleucine, liver is a major effector organ, and it can present with PALF or RALF episode, but LAS1 is the main culprit when it comes to overall cohorts and liver failure. They do have progressive liver disease. You can see remodeling steatosis, and you can see, especially in MARS1 deficiency, already cirrhotic remodeling of the liver. MARS1 has another feature that can distinguish from the clinical pictures towards the other two. While LAS1 it's the encephalopathy, MARS1 has a predominant lung disease, which gives rise to the main mortality as well. Most children that died from MAS1 deficiency died of a lung disease in their first year of life, so a relevant number of them. But that was also when this was recognized retrospectively sometimes, and you see the infiltration of this interstitial lung disease on the CT scan and on the radiology scan that you had seen on the left. And this is what you have seen with the MRI pictures, the encephalopathy with the basal ganglia, which can be also seen in some mitochondrial disorders. We see that in LAS1 deficiency with such an acute neurological involvement. And as we have seen, I put that here in green already, we have seen very severe disease courses in influenza. We highly recommend influenza vaccination in those children. Looking at the extrahepatic sign, that's again the repetition of that. So we have CNS and on acute episodes in LAS1 deficiency, ERs have a severe developmental delay, muscular hypotonia, which is very prominent, zinc deficiency, relevant that even on supplementation you cannot cure, and MAS1 deficiency is characterized with the interstitial lung disease if you look at extrahepatic presentations, and MAS1 can also present more in a cholestatic fashion than LAS1 and not always as PALF. So when we look at outcome, that's very variable and depends on the severity of crisis during the PALF. We will talk about the outcome we touch the outcome on a later point again. And for MAS1 deficiency, which is called ELLD, it's interstitial lung and liver disease, this is the main factor for outcome. Treatment is always antipyretic medication to avoid febrile infections, sufficient energy intake to assure anabolism state. Notably, it's proteins, so amino acids in the severe episodes as well, and to have influenza vaccination. And new is from 2021, this paper is that the cognate amino acid supplementation has an impact on the disease course. We don't know yet if if it has an impact on the recurrence of ALF episodes, but what you see here, that's the last one patient published from a group in Utrecht in the Netherlands. He was on as a mistake supplemented with isoleucine first and then started with leucine. And what you can see here, that the weight and the head circumference and the Hayes curve, they go up. So they recover from what is growth and what is weight gain as well. And when we looked at one case that we had of MOS1 deficiency with a neonatal cholestasis, once we started, he was at a cholestatic pattern with a bilirubin of 20 milligram per deciliter and the direct bilirubin around 4. We started supplementation with methionine, and then all the liver pattern as well, the transaminases and the gamma GT, they went down. So it was impressive, especially here with the bilirubin course, and stayed normal until now under the methionine supplementation. And also the inflammation that he presented with went down, but we need to say we added as well anti-inflammatory drugs before, so we don't know what is this the specific methionine effect only, but the liver effect was only on methionine before. So that was so this is an upcoming treatment possibility in this group, and we are running now a study, a prospective study to evaluate the liver symptoms and also neurological disease in these patients on cognate amino acid supplementation. When we talk about disorders of protein metabolism, we should also talk about a more classical metabolic disease, the urea cycle disorders. They can present, or mainly two can present, with recurrent acute liver failure that I mentioned here. The most prominent one, most frequent one, OTC deficiency, ornithine transcarbamylase deficiency, and Triple H syndrome. Here you see the urea cycle from the Vado-Mecum metabolicum. So if the OTC does not work, what's rising, the ammonia cannot enter the urea cycle. You see uric acid, you see a use of arginine, so arginine goes down. That's the biochemical pattern. Onset can be in infancy, but the leading sign is not the acute liver failure. The leading sign is the lethargy and the hyperammonemia in the thousands micromole per liter. And this is the early onset, mainly as it's X chromosomal inherited. This is mainly in male babies, and that you should always keep in mind we measure ammonia always in the liver disease, but if you have thousands of ammonia, you should think of the urocycle disorders. The second one is the deficiency, which is very rare. It's deficiency of this transporter just in the step before, and with this you come to the Triple H, which means the hyperammonemia, which you get because the urocycle is not running, hyperornithinemia because the block is just right here, and you see a rise in the cytosol and then the blood of ornithine, and homocitrulline as a consequence rises as well. That gives up the name. It's an ultra rare disease with only I think a couple of patients in Europe that are known to me in the literature at the moment. And so there's a very few data on the long-term prognosis and clinical course. What we can say is there's regeneration of liver function in the interval, and we have a progressive neurological disease in this type of disease with a spastic diplegia in the Triple H syndrome. For treatment, this is mainly metabolic treatment and assuring anabolic state with high glucose infusions. Then, of course, ammonia scavengers that you use in the long term, but as well in the acute phase. The main predictor of outcome is the ammonemia that you have on the first crisis. That's giving you rise to the neurological outcome. And liver transplant helps to avoid recurrent crisis in these children, and can be considered in high frequent crisis and very severe disease types, but and helps as well for growth and weight and height gain. But there's controversial data if it really helps as well for neurological outcome at the end, in compared to the metabolic treatment. Now I go, again, it goes back to Innsbruck, Georg, who tells us about endoplasmic reticulum homeostasis and your Golgi transport.
Thanks, Dominic. You can go to the next slide already. So this form of transport trafficking diseases affect or diseases, we will talk about the Vogel syndrome, which is located in the ER, NBUS deficiency, RIN1 deficiency, and the Kaufman syndrome. All three of them are important for retrograde Golgi to ER trafficking. Next one, please. So I'm going to start with the Vogel syndrome. Here, the affected gene is called EIF2AK3. Easier to remember is the protein name called PERK, which is one of the three pillars of the unfolded protein response in the ER. So whenever you have an excess load of unfolded protein in the ER sensed by chaperones, the ER stress pathways are activated. This is ATF6 alpha, PERK, and IRI1 alpha. This leads to an attenuation of protein translation. At the same time, the translation of chaperones is upregulated to overcome the excess unfolded proteins within the ER lumen, and also the ER associated degradation pathway is activated. And whenever unfolded protein stress is sustained and cannot be overcome, apoptosis programs are initiated to finally solve the problem. And as PERK is expressed ubiquitously, this is typically a disease affecting organs with high secretory load. And this is why all patients present at first with a neonatal diabetes mellitus. This is typical for Vogel-Wells syndrome, as the beta cells of the pancreas have constant secretory load with insulin. And the second most prominent phenotype is our hepatic phenotypes. Next one, please. And these are typically episodes of acute liver injury or acute liver failure triggered by benign febrile infections as respiratory tract infections. Native liver survival is not that bad, but I think, what we have tried to resolve that in a larger cohort 2 years back. But this is, of course, a little reporting bias. I think many patients, particularly in regions of suboptimal medical care, eventually die of unchecked diabetes. But also it's in a severe crisis of acute liver failure, as we've done for 2 patients in Innsbruck, one in his second crisis and the other one in the third crisis. We opted for liver transplantation, which then ultimately solves the problem of recurrent acute liver failure episodes. We don't know, however, whether these episodes cease over with age or not, because we don't have that much of follow-up. Next one, please. So also NBUS deficiency, RIN1 deficiency, and Kaufman syndrome share similar phenotypes as Vogel-Wells. Typically, all RAF episodes are triggered by febrile infections. The 3 of them present early during life, about the first year of age. Mortality might vary though. Next one, please. What's also interesting that the 3 diseases share at least 3 similar multi-system affections, one being the liver, as mentioned, the other one being the skeletal system, and the third one is growth retardations. But other symptoms or affected organ systems as the immune system or the musculature might vary between the different diseases. Yeah. Next one, please. So this is also, Dominic has touched it already a little. This is trying to separate the 3 entities by biochemical means. And what's quite striking is that in NBUS deficiency, you have very high transaminases. I think if you press next, Dominic, you will get the frames. Yeah, and in Kaufman syndrome, on the other hand, you have higher bilirubin and less prominent transaminases. But I think in clinical routine, I think it might be, if you have the choice between the 3, then it's okay. But I think every one of us would run genetics. Yeah, next one, please. I think this is also important to, I think once you have established NBUS deficiency or suspect as NBUS deficiency, This is important to understand where the mutation might sit and how the presentation of the patient might vary. So you appreciate three prominent domains in this protein, one being the beta propeller, the second the Sec39 domain, and the C-terminal domain. And if you have mutation, the carrier mutation and the beta propeller and the Sec39 domain, you have episodes of acute liver failure, but you've also more extrahepatic manifestations as short stature, growth delays, with mutations in the beta propeller domain. On the other hand, patients with NBUS deficiency and mutations in the C-terminal domain do not present that much with acute liver failure, but extrahepatic manifestations as well as facial dysmorphologies. Next one here summed up again. Yes, so this might be already helpful to discriminate patient cause. So NBUS deficiency typically presents early during life with a mean of about 1 year. And next one, you see that episodes, as here clearly put by Dominic and his group, that after about 10 years of age, you're probably in a safe zone, and the likelihood of recurrent episodes is rather low. Although, as here marked by the asterisks in red, there are outliers to every rule, and this was a patient in his early adulthood with a acute liver failure episode and died due to mismanagement, as the treating doctors were not aware of the underlying disease. And this already brings us to the last topic. Dominic is going to touch again with management and the outcome.
So thank you. Yeah, I'll talk a bit about the management. We have seen a bit of management already in the slides that we have seen before and talked about before, like the cysteine source in TMU or mitochondrial disorders. I will touch on common effector pathway first. So here you see, you rediscover that we have talked about NBUS, RINT1, about the PERK, and then RS deficiencies and protein translation, which happens in the endoplasmic or at the endoplasmic reticulum, and the mitochondrial disorders here with TRMU. And then that febrile infections or other triggers can lead to stress, and we do and one common effector pathway that this mitochondrial disease can then lead to increased reactive oxidative stress, and ER stress as well can lead in a secondary pathway to increased reactive oxidative stress. So there's a hypothesis that N-acetylcysteine is not only a cysteine source in TMU, but helps to restore the reductive potential of the hepatocytes, as this is in a common effector pathway paracetamol intoxication. So it might be of interest to look again on the on this subgroup of disorders leading to acute liver failure and recurrent acute liver failure. If we can find and measure this increased reactive oxidative stress, we are setting up something to gain more insights into this, and then to understand if there's this subgroup that might benefit from an N-acetylcysteine treatment, and it's my hypothesis that they do. But the overall group of pediatric acute liver failure, as shown by the PALF study group, have not. So there was no significant difference. So it was not introduced into the standard protocol managing acute liver failure in childhood. And also this gives rise to new treatment targets, of course, genetic targets, but as well to look more downstream on ER stress, and not only on reactive oxidative species that only seems simple, as there's an already clinical use drug here. When we look at those groups where you have less outcome, or we have not talked as a whole group. There's been one paper from the North American group as well. So we say that mitochondrial disease, they present early in the first month of life, while the others that are highlighted here have a median in the last months of the first year of life. So with 9 years of age, 9 months of age as an onset median, and those episodes decrease with age. And this is also true for this is true for the mitochondrial disorders, mainly for TMU already after the first year of life, and while DLD also decreases with age. It can happen as well during adolescence and adulthood. But many patients stabilize, and the crises are not that prominent, not that life-threatening. The overall mortality in this group of the 4 disorders written here above is 70%, and the median age of death was 2 years. And the main cause is acute liver failure or multi-organ failure. If you look at the 10-year survival by disorders, you find that that ILFS2, so it's the subgroup of NBUS deficiencies with a 10-year survival of 89%, SCO1 100% in the published cases, in RINT1 deficiency with 67, so it seems more severe, but it's also less cases that have been published, and LAS1 deficiency with the same, around 2/3 as well. So it is, RALF is a severe phenotype, a severe clinical presentation in early childhood, can be self-limiting, and it's difficult to tell how to address the treatment when it concerns liver transplant. We have now talked about specific possibilities with medications, but we should think about liver transplant, native liver survival as well. This is now from a slide from the NBUS group as well. When you look here, the overall survival is promising, as you've seen on the numbers, and the native liver survival goes down because there is in combined and ILFS2 deficiency. You have transplanted children, and this is the fragile period of time in the first years of life, up to 10 years. We've heard that there's the last episode normally. And so this is the time to think of, and we should think when to do. Liver transplant was performed in those 4 disorders in 11% of the children with this monogenic RALF disease that you can find here, in 26 patients. And the median age of transplantation is similar to the median age of death, around 2 years of age. An indication was normally during one of the episodes, and none of the transplant has been performed during the stable remission in order to prevent transplants. And the transplant is successful, so it's efficient. You have no disease recurrence after a liver transplant reported in all of these 26 children. So that's great success, one could think. But the 5-year survival rate after liver transplant, for example, and for NBUS deficiency is only 70%. That's not so promising compared to the 5 years liver survival in general after liver transplant. And that's making this as well specific, maybe, because in NBUS deficiency we have the immune dysregulation that we need to understand better, and treating or using immunosuppression in these patients can also provoke new problems. So it was no recurrence of liver disease, but then immunological problems, chronic problems revolving. So we need to think of, we need to more data in order to be prepared when to advise a liver transplant, when not. So liver transplant remains controversial. It remains controversial in the disease groups where they have potential severe neurological affections. We've heard about the mitochondrial disorders. TMU does not have severe neurological involvement in MPV 17 or DGOK. It depends on the genotype. We just had one MPV 17 patient transplanted 3 days ago of our patients due to the liver phenotype, and we had a long discussion about ethics and decision making in order to find our way through, and the genotype promised but good neurological involvement. So we will see. And but on the other hand, we need to say as well, it's not only controversial because it might be a life-limiting neurological involvement, it might also resolve spontaneously by after the first year of life in TMU deficiency, or later in life with the other recurrent acute liver failure syndromes. So and mortality despite liver transplant is reported. So that it's a balance to be found, and we need more data and experience to be up to date and to make good decisions. I think liver transplantation can be considered as a last resort therapy in life-threatening situations like fulminant liver failure, and but therefore you need to be prepared, maybe to have a backup as a living donor, with a living donor being already examined for liver donor transplantation might be an option that we have chosen in a couple of those cases. and to rediscuss the background and to achieve more data to choose the best decision in the future for these groups of children. So that's maybe the last words that we can take, and now we have as we thought 45 minutes of presentation, and we are happy now to that you attended this webinar. We are open for discussion and more questions with these pictures of our two cities again from the children's hospitals and our cities from Innsbruck, and greetings from here in Heidelberg and Innsbruck. Thank you. Thank you.
The weather's always good in our cities,
as you can see, but there's a bit more cloudy in yours. So invite maybe Norman back to stage, right?
Yes, thank you very much for the really fantastic talks and great overview about this very important topic. So please, if you have any questions, feel free to write down in the chat. So far, I can't see anyone. Emma raised her hand.
That was a brilliant, really brilliant webinar. Thank you very much to you both. Can I just ask, so if you have a carrier status for particularly variants of unknown significance, I mean, you know, I will send genes or the genes I think of in scenarios where I've got either obviously Ralph, but you know, sometimes if there's an odd feel to an ALF and they get better spontaneously and you know, it's indeterminate. But what about variants of uncertain significance, particularly in the Het state? You know, I mean, how much should we be looking at this?
Georg, you want to start?
Yeah, I try to at least. I think this is the question every one of us hates, I guess, because this is particularly if the episode has resolved and you don't have much to prove your hypothesis on anymore. I think it comes back to what Dominic and I have shown a little, how the presentation was accompanied by biochemical tests, by maybe whether there's lactic acidosis. I mean, this is not very specific for acute liver failure, but what you might consider then, particularly if it's an unknown significant variant affecting a mitochondrial gene, is whether to perform liver biopsy afterwards and see whether you can perform respiratory chain tests to see whether this narrows it down. I would follow it up, of course. I think this is particularly when the second episode occurs. This variant of unknown significant might be more significant then. So it's very difficult, and this is an excellent question. I would take it seriously, but I'm not sure whether it helps you explaining the first episode.
I would emphasize your approach, Georg, and I think functional testing is maybe king here as well. That if you can, even using fibroblasts to understand better, but it depends on the classification. The ACMG, so the American College of Medical Genetics criteria, allow from phenotypic spectrum, from phenotypic, so biochemical patterns, but as well from functional testing in for example, fibroblasts. And I can say that we have diagnosed a couple of patients. We cannot, so we offer for NBUS, we can offer functional assays that can maybe then also change a variant of unknown significance to likely pathogenic. We did that with one DLD case in our lab as well. So we at the end had a immunofluorescence with lack of DLD as a proof. So we try to then to get there, to follow up with this. I think that's the way where biochemical and functional testing is still very important as well in the field of genetics. While I think metabolic labs will close for diagnostics in the future, maybe they will be very important for functional testing to understand better the variants.
Okay, so we have one question now in the chat. It's the question about the usual supportive treatment in metabolic acute liver failure before the definitely diagnosis is reached. So particularly regarding the use of fat-soluble vitamins ursodesoxy, UDC, and NEC, acetine.
Well, I'm in favor of NAC. I think this is, I don't see, I think at least if you have a high suspicion of such a disease where it might be beneficial, and this is, we all follow the same workup, I guess, for ALF. And I would, if you have your doubts, or I think if you have your hints that it might be in the spectrum of diseases we have touched now, I think a course of NAC analogous to paracetamol intoxication is worth a try.
That I would say as well, when it calls more about metabolic management, if there is mitochondrial disorders suspicion with high lactic acidosis, then I would also introduce, this is a big discussion in the metabolic field as well, but I would certainly introduce thiamine at least 3 times 50 milligrams a day. And I would also introduce riboflavin if possible with 3 times 50 milligram a day, as you've seen. And then it depends a bit on the patterns. One could think when you exclude fatty acid oxidation disorders, get carnitin to promote a bit of fat acid energy metabolism for the transport into the mitochondria. I don't think that has a big issue, but if you have a mitochondrial pattern, apart from NAC that I'm in favor with as well, I would also use thiamine and riboflavin in the first on the first run, because you don't make any harm on that. You should think of if you need them on the long run. But if this helps to improve pyruvate dehydrogenase action and the electron transport, the respiratory change with these 2 drugs do, then this is as well worth a try at the beginning if you have a pattern like this.
Okay, so I have one question. What do you think is the value of, in general in acute liver failure, but also especially for these patients, what is the value of liver biopsy for diagnostic workup, if it's possible, of course, in the case of, say, acute liver failure, depending on many things. But if you do, what do you think?
I might start. I think it depends on the setting, of course, but if you have a fast pipeline for genetics, I think I would not go for liver biopsy as the first approach, especially not in the acute setting. But if you have a RALF, you could think of doing it in a second look after the liver failure. And I would be interested to see those biopsies from a functional and scientific perspective. But from a patient perspective, I think in most cases when you find pathogenic variants and the cause via the genetic means that we have, I would be reluctant. I would step back and avoid the liver biopsy in those children, at least if they recover liver function. Georg,
So in our center, usually pathology is still quicker than the geneticist. Only maybe but I think this is the old question. During severe coagulopathy, I would not do a biopsy, because if you have particularly high transaminases, I don't think you learn that much, except how a dying organ looks like. I think this is the problem, that the diagnostic yield is not given during acute liver failure, or might not be given, and might not outcompete the risk of the biopsy.
And I think I think it's the other way around. You're still faster maybe with the biopsy and pathologist, but with the whole genome sequencing for critical age children, we have seen now a couple of studies like the Baby Lion study in Hanover. We are having one in Heidelberg now, and with the nanopore technology for a panel, you can have in 24 to 48 hours, you can have at least for a couple of genes, you can have an answer. And I think we should rather work on that. And the pathologist is still faster than 48 hours, but 24 to 48 hours is an achieve and goal to be achieved.
And if you have a variance of unclear significance, do you think there's benefit for functional testing in liver biopsy compared to fibroblasts?
Yes, I do think there is a benefit, but then it's to be compared between the benefit and the risk. But there is,
Okay.
I think there might be a benefit for mitochondrial mtDNA depletion syndrome as well, because that might be different in different organ systems. And so this is one benefit you can have. And so that's the major point. But functional testing in liver biopsies is also not easy, right? Because then you cannot keep them long in culture.
Yeah. It's true. So I can't see any more questions on the chat. I don't want to overstress it, but just came up another question in my head. You mentioned that after transplant, NBAS is doing not the same well like classic liver transplant, I would say, maybe due to the immune dysregulation and the adding of immunosuppression. And there's always a discussion in the unclear acute liver failure that it can be some auto-inflammatory aspect, and that it's worth to give or to try to give prednisolone to rule out this area. Do you think it could be harmful for NBAS patients then?
To give prednisolone?
Yeah.
There's single reports from personal communications where that had been useful. We know there is immune system affection. We have proven that there's NK cell functional deficiency, which can be maybe linked to like HLH, so hemophagocytic lymphocytosis, and there might be a role from the lab experiments that we did, and we're trying to submit still a paper on that end of this month, is that we do see even without inflammatory or like without cytokines added to the cell culture, we do see already on temperature elevation a clear different pattern of stress in the cells. But I think there is a role for as additional role for the immune system. So yes, there might be a role, and I don't think that it does a lot of harm, but there's not a lot of experience in it, and I'm in touch with the centers that have done and experienced a bit with it, and there might be at least a subgroup where this can be of benefit.
Okay. So if there are no other questions, I want to thank you again for your great talks, really fantastic. Thank you for your time and preparation, and was very interesting. Thank you all who joined this webinar, and I wish you a nice evening. Ima, do you want to add something?
No, just delighted to hear that. That's brilliant. And again, this will be available on the ESPGHAN YouTube channel for any catch up, and you can spread the word. Thanks again.
And see you all at ESPGHAN in Lille in June. Bye.
Bye. Thank you. Danke dir.
Ja, danke dir.
Die anderen jetzt dann noch alle da? Ja, ich hoffe, ich melde mich gleich nochmal. Ciao.
Ciao.